Hello, everyone. For those who don't know me, my name is Taylor Locke. I am the current regional chairperson for the Americas region with AVA's Mental Health, previously Global Mental Health Peer Network. Thank you for joining us for part 2 of our webinar series on the power of peer support. We have some lived experience experts who will be joining us, sharing their perspectives with some presentations, and we will open up for Q&A at the end. So first, we will have Laura talking about the history of peer support. And we will go ahead and start sharing. So Laura, you have the floor, and I will advance the slides for you.
Great, thank you. Well, good morning on the West Coast and good afternoon or evening, wherever you might be. I'm Laura Van Tosh. I've been involved with the Global Mental Health Peer Network and now AVAS since 2021. Very, very honored and pleased to be involved in this network. I do want to let you know I am going to be speaking about the history and brief of peer support. And just want to note that this is history from the United States, which is where I currently live and active in the peer movement and have been since actually 1985. Our history is long and deep in the United States, and I was kind of humbled by that and then realized as I was pulling this presentation together that the world's history really needs to be told as well. So I'm really excited about thinking about how we can weave our respective histories together. Maybe that could be a project that we work on in the future. So I just wanted to bring that up at the start to let you know that there's a other history, obviously, from other continents, other countries, other regions, and I'll be speaking mostly again about the United States. So thank you. And Taylor, I've been ready for the next slide. Thank you, Taylor. Well, why does peer support matter? First of all, lived experience can help others pursue recovery. Peer support is an avenue into recovery. There's research and new programs that are developed practically daily nowadays, especially with AI, about the promises of peer support. Peer support provides for social, emotional, and practical support beyond clinical care. That's actually an asset given our respective countries and other issues around healthcare reform make it so that we need to locate other kinds of practices and services to help us maintain our recovery in the community. And also peer support matters because it complements professional expertise with shared experience. This gives us an opportunity to combine services and peer support together, working with clinicians and other people interested in supporting our recovery in the community. Next slide, please, Taylor. Thank you. Well, there are early roots of peer support, and most of the information that I've brought together come from some published research as well as monographs and reports that were developed at the national level to document peer support overall. At Fellowship House, Fountain House in New York City as one of the earliest kind of peer support type communities developed in the United States, where there were members of Fountain House that came together in kind of a clubhouse setting and decided that they wanted to create a program. And that's how Fountain House was actually created in New York City, not by providers or service providers, but actually by clients ourselves that again came together and made that happen. Even earlier on in history, there were settlement houses, Dorothea Dix, other faith communities and societies that came together to support people in kind of community-based service settings. And that was really part of the early movements. Alcohol Anonymous was developed in 1935 by Bill W. and other anonymous type services were developed over the years after that. So these are kind of early seedlings of peer support that were developed again early in this last century. Also in the 50s and 60s, consumer and survivor networks, you'll notice the terminology has kind of changed. There were clients, ex-patients, psychiatric inmates, and now we have terms like consumer survivors. And those terms came up through the development of networks, again, mostly in the United States at this point in the 50s and 60s. Drop-in centers were developed. I forget, just lost the name of the drop-in center that Judy Chamberlain started in Boston. Ruby Rogers Center was the name of that drop-in center, and that was one of the first drop-in centers in the United States. And Judy Chamberlain was a longstanding peer leader in the consumer survivor movement, who wrote a book called On Our Own, which I would encourage all people who are interested in the peer movement to read, young or old. Newsletters were developed during that time. Advocacy groups began to form. The Mental Patients Liberation Front in Oregon and other community-oriented advocacy groups were developed around the country as well. Civil rights movements began to form at that point, or at least I should say civil rights movements that informed the dialogue for peer support and advocacy issues were also established. That was more or less in the 60s and 70s. Post deinstitutionalization meaning when state hospitals began to provide community alternatives for people to access services and not be in institutions any longer. In the 70s and 80s, there was a huge development of peer-run services. There were some national grant programs that were funded through SAMHSA, which is teetering now on its own existence, but SAMHSA, the Substance Abuse and Mental Health Services Administration, issued grant programs so that peer-run programs could be developed at the state level and also locally. Community programs were developed, self-help centers, outreach services began to get supported, and again were involving people who would go into the state hospitals, meet and support patients, and then work with people coming out of the hospitals back into the community. Okay, next slide, Taylor. At this time, really, in this 80s and into the 90s, workforce development became a really important part of the peer movement. People who, again, were mostly working in volunteer capacity and community programs and drop-in centers began to recognize that with credentialing and training, that people could start working in the field in positions alongside or in supportive roles on integrated care teams and other models in the community. So people really began, in terms of the civil rights issue, if you will, to recognize that, hey, I can do the kinds of work that other people are doing that might not be peers, but might be helpful. And maybe I could work with them with some training and credentialing and actually have a job in the mental health community. And that whole concept of taking one's experience and turning it into a professional role or a supportive role within a care team, for example, really turned, provided the peer movement with some incredible opportunities to engage in the system, provide specialized care, and promote recovery for really huge numbers of people. Now in the 2000s, we have 25 years plus of additional work that's under our belts, and people ought to be really excited and proud for all the work that took place way back in the 1980s. Taylor, thank you. One more slide here. Core principles that define, that guide peer support, empowerment. A couple of these principles actually I heard in the peer support section 1 of this webinar that was held a few days ago. Mutuality came up in that particular session. Support being reciprocal, peer sharing experiences. That whole idea of mutuality was really well discussed in the previous session. Other core principles, non-hierarchical approach, that relationships are collaborative, lived experience is central, and empowerment, where people have the ability to take over control of one's own recovery, which is really important for recovery to survive. Choice, respect and dignity, independence and responsibility are also super important principles that guide peer support. Next slide, Taylor. Evidence and outcomes. Luckily, there has been some research, and frankly, not just in the US, but really international, some great research that are bringing together evidence-based services together with research that's validating the role of peer support in service systems has been exemplified within the really healthcare field internationally. So very excited of what's coming up here in terms of outcomes, showing that the investment of peer support will strengthen outcomes when peers are part of integrated care teams. Peer support boosts self-efficacy and hope and recovery confidence. More importantly, too, now with regards to deinstitutionalization and not rehospitalization, that we might see the way our systems seem to be tilting right now, is the idea of reducing hospital and emergency use, which has come up now through innovative crisis care solutions and the ability for peers to work on crisis service teams. And that's supporting the evidence base and obviously clinical outcomes in very positive ways. Taylor, one more slide, I think. Impact through policy. Peer support clearly has put a dent in national policy in the United States. Some of these policy solutions and impacts have affected other countries and other processes to develop and shape policy that impact peers in various other countries. We are impacting parity laws, Medicaid reforms. I want to call out to Larry Fricks, who was a peer leader in the United States. He passed away in August, but due to his work in the state of Georgia in the South in the United States, back in the late 1980s, early 1990s, peers can now bill Medicaid to reimburse for services. So a lot of programs around the country hire more peers, and they can actually bill this national financing program called Medicaid and get paid for their services. That was a huge policy victory for peers in the United States. And I think that's impacted internationally as well. Actually, there'll be a celebration of life for Larry next week, and people are grateful for the work that he did for so many years. I'm going to skip to the Olmstead decision, which was passed in 1999, and that's a Supreme Court decision, which I encourage people to research online and learn more about it. Ruth Bader Ginsburg actually spoke and gave the oral decision, so that's actually recorded, and you can find that on the internet and listen to her voice talk about how the Supreme Court aligned itself with the Olmstead decision. opening up doors for people in institutions to leave and have choice in their ability to reintegrate back into the community. Olmsted was an ADA case, Americans with Disabilities Act, so both are intertwined, to keep that brief at this point. Finally, crisis system reforms in the 2020s have created programs called 988, which is an alternative to calling 911 in the event of an emergency, mostly born out of unfortunate deaths that have occurred among people calling for help and ending up in very awkward and challenging positions with the police, and oftentimes being killed or injured and dealing with police interactions. So crisis system reforms are crucial for a number of critical reasons. Finally, just want to call out peer respites as an alternative service which provide people with alternatives in the community to get crisis care that are peer run, peer led, peer researched, and peer financed. So that's an extremely important opportunity that's come up in our fields in the last, I'd say, 10 or 15 years. Next slide, please, Taylor. Thank you. Finally, for my talk, my presentation, we have three major takeaways to kind of boil down some of our lessons today. One is that lived experience matters. Peers bring unique insight and hope that professionals alone cannot provide. So there's so many opportunities there for lived experience engagement on our own, but also in collaboration with the service systems that we interact with. Evidence supports impact. Peer support improves engagement, recovery outcomes, and system efficiency. The impact of peer support is definitely notable and should be considered in the development of really all healthcare services, especially at the local level. And that policy and practice must align. Sustainable peer roles require supportive laws, funding, and organizational structures. All of those things are really a key part of involving non-consumers, non-peers that can help support developing those alignments that will bring excellence in terms of policy and practice. The last slide primarily if you want to show that slide, Taylor, is a set of citations that were used in one way or another in terms of preparing this particular presentation. But all of them have rich material, especially historical material, and much more is out in the community and online as well, if you want to make your searches more rich and comprehensive as well. So thank you so much for the time today. Appreciate being able to share my knowledge with you all. And thank you, Taylor, for support with the presentation.
Thank you, Laura. Excellent presentation. I know that there's so much to cover with the history of peer support, and I think you did an excellent job in such a short period of time. And like you said as well, there's so many other perspectives outside of the United States that are also very vital to the peer support movement, especially with the recent push of a globalization for mental health, the mental health peer movement across the globe on looking at those different perspectives. So a lot of other stories to share in that regard as well. So thank you. Next, we will have Ruta, who will be presenting on task sharing interventions among peers. Ruta, you have the floor.
All right, are you able to see my slides? And no presenter notes, just the slides, right? All right. All right, thanks so much for having me. My name is Ruta Rangel. I'm a program manager at the Center for Global Mental Health Equity at George Washington University and a proud member of the Global Mental Health Peer Network. And I'm super excited today to give you a very, very brief overview of task sharing interventions delivered by peers. So I feel like this slide doesn't really need an introduction. We all know that mental health conditions are highly prevalent across the world, and the low and middle income countries actually bear a higher burden, with 80% of individuals who have mental health conditions living there. And we also know that we have this high need for mental health support, but we don't have enough mental health providers to deliver that support. And as one of the strategies to address this, we use task sharing or task shifting approach when non-specialists are being trained to deliver mental health interventions. And this approach is rooted in global health programs, in infectious diseases, maternal and child health interventions. And this strategy actually has demonstrated success in improving quality of care, its delivery and scalability. Very interestingly, however, when it comes to non-specialists, depending on the setting and depending on the target population you're working with, it's very important to ensure that the helpers or those non-specialists are chosen wisely, just to address the needs of the population in the best manner. And today our focus is peers who can deliver psychological interventions, especially those low intensity. But we also see that there's a lot of evidence of helpers being community workers, whether it's medical workers or community mental health workers. Mental health providers as well can deliver these interventions. Other interventions can be self-administered. And this list is not complete, right? We can have many other type of helpers, whether those would be nurses, primary care providers, or many others. And interestingly enough, I was looking at this diagram from the Mental Health Atlas that was recently released by WHO. And you can see that when it comes to mental health workforce, across different WHO regions, we see that similar distribution of psychiatrists. We also see more or less similar distribution of psychologists. But we see also a growing group of mental health nurses delivering mental health support, as well as peer support workers. It seems that some of the regions have less peer support workers as their main group of workforce. But interestingly enough, Southeast Asia has a very large group delivering different types of mental health support, which is very exciting to see. There are multiple psychological interventions that are low intensity and can be delivered by non-specialists, but I will just give a couple of examples because of the time, but this list definitely is not complete. There are many, many more. So I will briefly cover Problem Management Plus, Self-Help Plus, and Thinking Healthy program. So Problem Management Plus, or PM Plus, it's a transdiagnostic intervention, which means it's not designed to just focus on one mental health condition, but more of a range of symptoms. And it is typically delivered in 5 sessions and has 2 different modalities. So you can deliver it either one-to-one, like individual support, or as a group intervention. And depending which modality is being chosen, the minutes per each session could range between 90 and 120 minutes. And the training as well, for individual training, to train non-specialists, it takes 80 hours. For group PM Plus, it takes 96 hours to train them. And this is a very, very small map, but essentially what it demonstrates is randomized controlled trials that have been done to assess Problem Management Plus effectiveness in low resource settings. So low resource settings could be in low and middle income countries, as well as in high income countries, thinking about like refugee settlements. And when we talk about randomized controlled trials, it's like a golden way of assessing effectiveness. That's why I specifically looked at those studies that covered randomized controlled trials. And we can see that when it comes to the delivery of Problem Management Plus, community health workers, nurses, lay workers, mental health workers, as well as peers have been used across the world to deliver this intervention. Specifically, I'm thinking of a study in the Netherlands, where refugees were delivering Problem Management Plus to other refugees. And the intervention has demonstrated improvement in different mental health outcomes, and not only after the intervention, but also a 3 months follow-up. So we did have some sustained effects. Very briefly, another intervention is called Self-Help Plus, and it's a World Health Organization as well as PM Plus low-intensity intervention. This intervention is actually based on acceptance and commitment therapy, and is typically can be delivered to groups of up to 30 individuals. So it also has 5 sessions, but those sessions range around 2 hours per session. And it takes this time 40 hours to train non-specialists to deliver Self-Help Plus. And across the world, thinking about these randomized controlled trials, we've seen that this intervention can be delivered to refugees, asylum seekers, as well as healthcare workers. Because the intervention can target relatively big groups of people, it is highly scalable. One challenge that I saw is that in many different papers, the non-specialists are described as non-specialists without too much detail. So it's kind of difficult to determine whether they were peers or not. But there's definitely some studies, and one of them I'm thinking in Turkey, that again delivered peers delivered this intervention to their refugees in the refugee settlements. And interestingly enough, the effects were not seen right after the intervention for different mental health outcomes, but they were relatively strong after a few months follow-up. And finally, another intervention that I would like to mention is Thinking Healthy program. And this intervention is specifically focused on perinatal depression, and it's focused on cognitive behavioral therapy. So it targets different stages of perinatal stages, such as preparing for the baby's arrival, early infancy and late infancy. That could be around 8 to 10 months after birth. And again, specifically focuses on depression. And in 3 different studies that I found, 2 of them focused on specifically peer delivery. So mothers who already had children were supporting women who were in this perinatal stage. And again, this has demonstrated pretty strong mental health outcomes across different time points. This is a relatively long intervention. It takes up to 16 sessions, and only because it touches upon these different stages of women expecting a baby and then baby's arrival. And each session takes up to an hour, and the training of non-specialists can last 5 to 10 days. Very briefly, this is a bit hectic slide, but what it demonstrates is if we look at depression and these 3 interventions at 3 different time points, so one time point is up to 4 months, another time point is 6 to 9 months, and then finally up to a year, we can see that some of these interventions, so those that are specifically in green, actually keep the sustained effects up to a year. So it has quite some impact on depression. It's slightly different with PTSD, with the post-traumatic stress. It's not, it's highly significant at the beginning, right after the intervention, but we couldn't find much of the sustained effects afterwards. Functional impairment is a little bit sort of mixed results. We can see some effect at each of these stages, and Thinking Healthy program actually was the one that had the sustained effects up to a year. So when it comes to peer-delivered mental health interventions, it's really important to have these considerations in mind. So it's essential, the familiarity with the target population, to ensure that the peers understand the community that they are delivering the mental health intervention to. But sometimes if we have a very small community, we might be risking a little bit of breach of confidentiality. So this is something that we need to always cover in the training with the peers or any other non-specialists. Also, settings and duration is important. So if these mental health interventions are delivered, let's say, in a primary care setting versus humanitarian care setting, it will differ what kind of intervention is chosen, right? Because in a humanitarian setting, we need attention right away. Perhaps we need to choose a different intervention rather than selecting something that lasts 5 or even up to 16 sessions. One thing to note that even though some of these interventions were not fully delivered, they did still show effectiveness, which shows the power of the intervention and the peer delivery. And finally, quality matters. So we need to ensure that supervision is in place to ensure that there's no burnout of the peers or non-specialist providers, and ensuring that there is a structure for them. Whoops. So finally, in conclusion, that peers are essential. They are central in making recovery possible and strengthening communities. However, it's not just enough to train non-specialists to deliver the intervention. We always need to take into account and deliver supervision and ensure that there's self-care is involved to protect both the helper and the person being supported. Thank you. I'm sorry for sprinting through this so quickly.
Thank you, Ruta. That was great presentation. I only knew kind of surface level stuff about task interventions before this, so extremely informative and well done with getting, again, so much information in just such a short period of time. Next, we will have Isaac, who will be talking specifically about youth peer support. Isaac, you have the floor.
Perfect. Let me know if you will see my screen. Perfect. And while I'm doing the whole present, let's just get a big stretch in, y'all. I've been at my desk for a while. Just reminder, ergonomic health is great. Yep, perfect. Great. And with that, now I'm sharing screen. Great. So yeah, today I'll be talking a bit about youth peer support, what it is, why it's important, and kind of what the state of the field currently looks like. Most of you here know me, but just as a refresher, my name is Isaac Lara. My pronouns are he, him, his. I always say I'm on a mission to create a happier, healthier global community. And a bit about me and my relationship to the youth peer movement is, first and foremost, I'm a person with lived experience. I've previously served as a youth peer supporter, and also I currently conduct lived experience research and youth peer support advocacy work across multiple different organizations, including AVE's Mental Health. So a bit about today and what we'll be talking about. One, and what I hope you all will take away from this presentation, is one, understanding the unique values of youth peer support. Oftentimes when we're talking about peer support, we understand what it is and the values, but youth peer support tends to be a bit more nuanced and it manifests differently across settings. So I'm hoping by the end of this, you all will understand those nuances and the differences between youth and adult peer support and the unique values it offers. Exploring practical strategies for adapting existing peer programs that encourage youth leadership across different settings. And then lastly, we're going to be identifying a few successful models of existing youth peer support programs, primarily in the US, since that's where most of my work is focused, but learning how can we implement similar approaches across global settings, again, to expand youth peer support globally. Now, before we even get into all of that, I wanted to ground our conversation and first talk about a few definitions. First, what do I mean when we talk about peer support? Peer support, especially when you put it in a global context, typically really refers to this broad range of support in which people with similar lived or living experiences and mental health challenges are supporting each other. Here in the US, we're used to peer support being much more formalized and where it may be tied to certification or credentialing. But internationally, and also in contexts where it's particularly youth peer support, there is not as much of a clear formalization. And so peer support can also manifest as volunteering roles or ad hoc support roles. Lived and living experience, of course, refers to the knowledge and wisdom that we gain from directly experiencing these challenges and navigating systems of mental health support. And lastly, when I'm talking about youth, I'm usually referring to ages 12 to 25. And more importantly, it's usually referring to that that age where you're transitioning into adulthood and experiencing a lot of life changes, more intense identity formation, etc. But that's what I'm talking about when I'm thinking about young people, at least in this conversation. So now we've defined peer support and youth separately, but what is youth peer support when you combine it? So youth peer support, similar to regular adult peer support at its core, does center mutuality and lived experience, and really the sentiment of deconstructing power dynamics we often see in traditional mental health care settings. With young people, there is also this consideration of ageism and how does age and power play a role as well. So mutuality is even more important in the youth peer support relationship when we're talking about how do we share power with young people. Similar to adult peer support, it does complement clinical services, it does create connection, and it does involve sharing resources. So similar to adult peer support, the young people that are engaging in this model are also traditionally either in group settings or one-on-one, working with other young people to see where can they relate, where can they offer support, and where can they share local resources within their community. The other piece of this, and really where we see it manifest across youth institutions, is it's not as formalized as a one-on-one service where a young person can go and seek out a peer, but oftentimes they're seeking a trusted peer or a friend within their community, seeking mentorship and advice. But when I'm talking about youth peer support, generally I'm talking about that one-on-one relationship and really one young person supporting another young person rather than an adult ally supporting a young person. So unlike adult peer support, where again, we're thinking of this very intense model of a peer support specialist providing a service to another peer, youth peer support is a bit more nuanced and it really should be thought of as this continuum of care. This graphic is a courtesy of Mental Health America, where they break this down into three models, where on the blue, the biggest circle, is the lowest intense form of youth peer support, where you might have peers, kind of like even this webinar, providing general educational training so that peers and other young adults understand from another young person general topics around mental well-being. A bit more intensely, we have going where young people spend their time. So young people intentionally reaching out to other young people through services or other things as well, to again, more personalize and more strategically engage with young people. And then lastly, then the most intense is embedding peers into youth serving institutions. So this is what we may think of when we think of adult peer support, where there are actual dedicated spaces and services for people with lived experience to receive mental health services and support from peers themselves. So I'll be going through each of these models of the continuum and giving a few examples of what does this look like, primarily in the US, and what this could look like for you and your programs as well. So starting off first with universal approaches, And this is the lowest intense, and by intense I mean just to what level of training and service being provided, is training all young people in mental well-being. Oftentimes, many of us, of course, are in this mental health bubble, and if you're in this webinar, if you're watching this webinar, you're probably in that bubble of, we know a lot of common mental health knowledge things, but the average young person may not. And so the effort for training all young people is really to train them in mental health literacy and really empower them with confidence and make them feel competent in general support skills. This can include things like QPR Ask, which are two models popular in the US around very general mental health education around suicide. How do you identify and talk about suicide? And more broadly, how do you introduce the conversation about mental health to your peers in your local community? Peer-led mental health education. So examples of that include a recent global effort was the Mental Health Literacy Collaborative, where they're creating materials globally for communities to have introductory conversations about what even is mental health, why is it important, etc. In university settings, this might look like peer-led education, where they're doing workshops on things like sleep, things like general health things, etc. And then lastly, creating a culture of support. So general destigmatization campaigns or social media campaigns, etc., really aiming at educating young people on why is mental health important. So although, again, the examples I gave are US, the same principles are very widely applicable around the importance of training young people, especially those who may not grow up in communities where mental health is talked about or where it is destigmatized, to ensure that all young people are coming from a place of understanding and from a place of non-internalized stigma. Moving on to the second approach is targeted approaches. And going back to earlier, this is really where we are intentionally going where young people are at within their local community. And this can include things like youth serving institutions, such as schools, clubs. It could also be community centers or third spaces where young people are predominantly present in. For example, Active Minds and NAMI are two prominent mental health organizations here across the US that are particularly, Active Minds specifically is very youth focused and more so targeting college age students. But what's more important about this is there is an existing relationship between the national organization and the various chapters and clubs at each university or high school. And the reason that's important is that the national chapter may provide funding, they may provide educational materials, or they may provide network connections to allow for workshops and other things. But the most important piece is that young people spend most of their time at this age in different youth serving institutions. And so it's a strategic idea to have peer presence within those spaces. Of course, within the last couple of decades, we've seen the increased use of the internet and technology, and really young people taking the lead in utilizing virtual and chat-based programs for support. Of course, there are things like the Trevor Project, 988, and other forms of direct suicide hotlines or warm lines where young people can directly go and seek out a peer to provide them mental health support. I also include Discord on there because I'm not sure if you all have seen this, but in my experience, I've seen it where young people are also creating an entire digital communities around mental health support where, although not clinical in nature, young people have entire servers dedicated to mental health support where they can share their lived experience, they can share workshops and resources with one another, and really they can do essentially mutual aid with one another in a space created by and for them. And this is becoming an increasingly popular trend with both Discord and also places like Reddit or Twitch, which is a streaming service for education as well. And so as we think about future peer initiatives, it'll be great and essential to think of how can we continue to target youth serving and youth created spaces to increase access to youth peer support. And then lastly, integrated approaches, which is essentially looking at how can we embed peers across all systems, both youth-serving ones and ones where, although not youth-led, youth are still participating in. So this can include things like dedicating physical spaces for peer support services. Alcove is one initiative I've had the privilege of consulting for the last year based out of California. And through their initiative, they've created about, I believe, 11 physical drop-in centers near schools and local youth serving institutions where young people can just walk and go to this physical community center essentially, and at little to no cost receive mental health services if needed, such as counseling or peer support, or if they just need a third space to do homework, for example. So creating more of these peer-led community centers so that young people can have a physical third space to reach out to when needing mental health support is great. The other components is integrating peers authentically and effectively into existing mental health systems. Here in the US, we are seeing an increased adoption of peer support in traditional mental health care systems, such as clinics, hospitals, crisis responses, etc. But there is still barriers around the authenticity of it and really the support systems that peers have. Youth peer support is still a very rare service that we see in these types of settings. Some states like New York, for example, have it a bit more robustly developed, but there is a need to, in addition to integrating peers more broadly, ensuring that we have some form of youth specialization so that young people specifically reaching out to these services can get support from another young person. And then lastly, ensuring that we are embedding and training peers in systems where young people are often at, but may not necessarily expect this type of support. For example, the juvenile justice system, foster care, and social services are areas where young people, especially our most vulnerable, are increasingly present in. However, peer support is completely absent from many of these systems or is, when present, not necessarily supported in the way it should be for effectiveness as well. So those are a few examples of kind of the different three tiers of how youth peer support has manifested today and ways that we can think about integrating youth peers across different settings and in different ways. But really, I wanted to end off by discussing how can we advance the youth peer support movement today and how can we support it so that we can increase access to youth peer support training and services. First and foremost is implementing youth peer support friendly policies, including funding. Here in the US, there's no secret that we have a very unique funding landscape at the moment, but even in a global setting, there is a lack of investment in youth peer support. We are seeing increased efforts to invest in youth mental health and youth well-being for our youth populations. However, youth peer support has not necessarily been a huge part of that conversation as well. So it would be great to ensure in all contexts that one, young people are empowered to access training, which requires funding to develop it, and two, that there are services and trainings existing that young people can access to become peer supporters themselves. And that goes into my second point, which is we need to develop and expand youth peer support trainings and services. Across the US, there's only a handful of states that have a youth specialized training. However, most states kind of default to telling young people, oh, just take the normal adult one. However, there are special considerations that should be made for young people, again, such as ageism, other things such as working within youth serving institutions like schools, and other nuances such as how do I set boundaries with my friends so that I don't get triggered, or how can I ensure like our safety, etc., and those things as well. So there is a need to develop more extensive youth specialized trainings. And then lastly, there is a broader need from especially adult allies to educate and combat miseducation and misinformation around youth peer support. Whenever I do talks about youth peer support, the first question I always get is essentially, how can we trust young people to do this work? Is it too much? Is it dangerous? What happens if a young person is suicidal or if they are considering harm, etc.? But those issues tend to not be unique to only youth peer supporters. If anything, I've talked to many young people who have still faced those same concerns with no training, and that's made them even less capable of addressing those challenges. So it's our responsibility as leaders in this space or as adult allies in this space to really challenge people's preconceived notions of who is allowed and who can provide support, and really ask the question of how can we enable young people to support in the systems that already exist and have been created by them. And that is it for my presentation. I can yap about this topic for probably over an hour. So yeah, I'm always happy to continue this conversation. You can reach out over email or connect with me on LinkedIn. I wanted to just do a brief acknowledgement that a majority of the content in this presentation was an adaptation of a previous one myself and a few members of Mental Health America's YPA conducted. So I have to give credit to them and their team as well for allowing me to adapt for this presentation. Yeah, thank you.
Thank you, Isaac. Again, excellent presentation. Always happy to hear you yapping about youth mental health and youth peer support. And again, thank you so much to all the presenters for your work of putting this together. With that, we will go ahead and stop recording and open up briefly with the time we have left for questions and comments.